back years, and he has not smoked for about 5 years, and he's an occasional drinker. And systemic inquiry didn't reveal anything much than the facts that I've already mentioned. And past medical history-wise, he does not have any previous medical comorbidity. Med score is compatible of more than 4, and he has good exercise tolerance. He has not undergone any major surgeries before, and there's no allergic history for food, drug, or plaster. And dietary history-wise, he's able to tolerate a meal for the time being, comfortable with small amount, frequent eating. And family history, he has good family support, compliant patient as well as family members, and there's no associated clustering of similar symptoms in his first degree family relatives. And his social history, sir, his activities and daily living and chores are intact, is independent, prefers surgery if necessary.
Before that, Subun, now, Musa, are we happy with the histories so far, or have we got to add anything more? Sumudu?
Yeah. I think it is very good. And it covered all aspects. Noise echoing.
And the rest of you mute the mic, please.
Yeah. One thing, what I feel, I don't know what others' idea about this is sort of, I think you don't have to say, I asked this question to find out this information. He said the patient didn't have nasal regurgitation, coughing, recent stroke, which is suggestive of neurological cause for dysphagia. I think you don't have to sort of suffix it with that. You just have to tell it, and the person who is listening to that have liberty to accept it in that context. Do you have to sort of what is others' opinion? I won't fail anyone, but sort of that distract my concentration.
What is Pramod then?
It's a good strategy at the exam to cover yourself, because you don't have to ask the whole sort of range of symptoms, so you can just get the attention of the examiner that you have addressed this. But I don't think it's necessary. I mean, because different examiners might have a different opinion or a viewpoint. So as long as you mention the symptom, and if the examiner questions you, have you thought of this, then you can say, yes, this is why I mentioned this.
Yes, sir.
You don't have to necessarily mention in each and every symptom why you're mentioning it.
Yes, sir.
Because you might get you might have a examiner who thinks differently and who was expecting sort of a different reason for the mentioning of those symptoms. So you leave it open. If
Yes,
at
sir.
all, if they ask you, have you thought of this, then you can come up with your explanation and tell them in the discussion.
And the other thing, you are mentioning certain extremely rare metastatic symptoms, nocturnal bony pain, early morning headache.
Yes, sir.
This we always listen, but we rarely see. I don't know. I would think that sort of the impression I get when I listen to these things, I'm not sort of reducing any marks, but this is just you are just going through what you have heard from previous students.
I think so. The issue here is the candidates are pressed for sort of questions to ask in the history, because other than esophageal cancer, hello, because there are only few questions that, I mean, only one or two symptoms in this history, so they are pressed for sort of the length information to mention in the history. That's why I think all candidates tend to ask these questions and mention, because they just have one complaint: dysphagia. Other than weight loss and loss of appetite. So I think that is the reason why most candidates go into these finer points and try to add some facts into the subs, or like increase the length of the history.
Yes, sir.
If I'm taking a history, and if I'm listening to a history, what matters for me is how well someone described the presenting complaint, or how well someone has analyzed the presentation. And if I think if someone has done it comprehensively, I think rest of it is you eventually pass the exam. You have analyzed the presenting complaint well.
Yeah.
But other things, I think you can. I don't think there is a exact way to do it. You try different ways, but then you adapt according to what you see in the examiner.
Yeah.
In the setting of the exam.
Yeah. I think it's important to highlight how this condition has affected his life and how he has changed his eating habits, how he has noticed the loss of those things, even the important negatives, whether he has noticed or he has not, like, with regards to his clothes and, changing his day-to-day lifestyle and so on.
Yes, sir.
You can nicely explain how his dysphagia was progressive or it wasn't
Yes, sir.
progressive on either side. So I think that explanation of the presenting complaint is very, very important, and you can grasp the whole board of examiners with that. Rest of it actually, even becomes irrelevant once you nicely present the solid. You have to always guide the examiners towards a specific sort of a few diagnoses, rather than just give out details that they can think of, everything in the world. So you just need to guide them, focus them, and narrow down the differential diagnosis by giving a nice description of the progression of the disease, I think.
Now, at the end of this history, very likely question you will be patched is ask you to give a brief summary.
Yes, sir.
Right? That will definitely differentiate a candidate who is just vomiting what he has sort of collected from someone else, or sort of candidate who is sort of giving a history from his on his own. So give me your summary. Yes.
One thing I want to notice is what about the etiology wise now?
So,
We,
can you hear me, sir?
Yeah. 4 months.
hello.
Hello.
Yeah.
If you think about cancer, of course, there are a lot of, factors which predispose to the cancer development. How do we need to talk about that at this stage, or like history of acid burn or whatever stuff, like there may be family histories and that kind of things? Or esophageal cancer, I don't know how significant it is from my knowledge.
Yeah.
Important at this stage.
He has discussed few causative factors: smoking, alcohol, betel chewing, and reflux disease.
Yeah.
And the things which he has forgotten were corrosive ingestion, and there are other very rare things. I of course pardon for those things, because basically he has sort of touched most common causative factors.
Right.
And
Okay.
Yeah, but now if a registrar is presenting, now let's say at the end of the history, I would like to have answers of a few important questions. One is whether the patient is having a progressive dysphagia. Of course, you have mentioned that in your summary. It's a progressive dysphagia, and
Yes.
how bad this dysphagia right now is very important for the management.
Yes.
What exactly we are going to do, and how urgent we are going to do it depends on how bad the dysphagia is. So
Yes, sir.
that's a key finding if you are summarizing this patient for the management. So progressive
Yes,
dysphagia of 3 months, and right now this is the degree of dysphagia. And then if it is a malignancy, you are talking about malignancy now because of progressive dysphagia. I would like to know whether the patient is having any complications of that. Any evidence of local infiltration,
Yes,
maybe voice change, coughing. So you can summarize everything together and say that the patient is not having evidence of local infiltration. And then if you are thinking of surgery, the important is whether the patient is a candidate for surgical management. So those 5 points, I think, important in your summarizing. I think these are important for the management.
Yeah.
Yes, sir.
Yeah. The summary is not adequate, I feel.
So why I shortened this?
For
Because
postgraduate,
if I directly say that that there is no local or distant metastatic evidence, so would that prove that I am thinking only one way, sir? This is definitely a malignant cause.
Not necessarily.
think
Not necessarily.
So I shorten it thinking that that's a
Right.
Now, this age, progressive dysphagia over short period,
Yeah.
3 months, the most likely cause is malignancy. Right?
Yeah.
So you can't hide it. Right?
Yes, sir.
yeah.
When
And
you
what do you
see
think
a
actually?
face-
Frankly, what do you think? Do you think it's a malignancy?
Yes, sir.
So can it be anything else? Can it be corrosive injection? Can it be achalasia? You
No,
think,
sir.
so you don't have to hide anything, as Musa said. It's if you think it is malignancy, there is no. Sometimes you don't need differential diagnosis. There is only
Yes,
one
sir.
diagnosis sometimes. So you don't
There's
have
no
to struggle for.
high-speed business here.
Yeah.
If you're confident, you don't have to be scared. Just present what you are confident of.
Okay, sir.
And you haven't mentioned here how bad this dysphagia is in the summary. Like, is he completely?
Yes, sir.
Can he tolerate? Is he on a liquid diet only, or can he tolerate solids? Or would
in the
be
dietary
important to
history,
manage.
I mentioned, but not in the summary, sir.
Yeah,
Yes.
yeah. At a postgraduate summary, we should be able to make a decision based on the summary alone, right? The next step,
Okay, sir. Shall I proceed with the
The
examination?
examination, yes, please.
Yeah.
So generally, this patient is a
Yeah. How the
team build patient.
support.
Yes, sir. Yes, sir.
Now at the end of the history, if you are examining, what is the aim of your examination? Why with what purpose do you examine this patient?
So the history is suggestive of a esophageal malignancy. So my examination is to identify metastatic disease, as well as his general build up, his nutritional state, and able to tolerate a major surgery.
Yeah,
So those are the three key elements of my examination.
Yeah. Okay. So that is why you examine this patient.
Yes, the three aims are to identify this.
Yeah.
Hello, sir.
Yes. Okay. Carry on. Yes.
Right, sir. So this patient is a thin build patient, currently weighing 49 kilograms. We have increased it up from 46 kilograms. I don't have exact details of his height, sir, but I want to measure and do a proper nutritional patient is in the wall. And he's not pale, and there are no features of hello.
We can hear you.
Hello. Oh, yeah. He's not pale, and there are no features of any nutritional deficiencies. I was looking for rare findings of coarse skin, bito spots, ankle edema, and more significantly, he has poor oral hygiene. He has a lot of dental caries with him. there's no cervical lymph nodes, and there's no Treacher's signs was negative. And abdominal examination was normal. I was looking for, sir, any hepatic enlargement, any ascites, or any central abdominal masses which indicates a paraortic lymph nodes. And respiratory examination, again normal. I was looking for features of effusions, as well as, since he has been a smoker, I was looking for features of COPD, which would have implications on the surgery. And as Musa mentioned, there are rare things. I was looking for bone tenderness and any neurological deficits. Is that all right, sir?
Right. You said sort of poor oral hygiene. You said sort of we had sort of dental caries.
Yes, sir.
What is its relevance to this patient?
So the thing is, now if we are to go ahead with surgery, if the primary tumor is resectable, this is going to be a major thoracic surgery. So one major killer in esophageal major thoracic surgery is actually aspiration and pneumonia related deaths. So poor oral hygiene makes it worse. So there can be due to dental caries. Actually, there can be dental the caries can get asphyxiated, and due to poor oral hygiene, there can be harboring of lot of anaerobes in the oral cavity, which again would make the aspiration pneumonia severe. So for those reasons, I'm concerned about the oral hygiene of this patient.
Okay.
Yeah.
And the nutritional assessment.
Yes,
now
sir.
3 months of nutritional. Now we had sort of dysphagia for 3 months.
Yes, sir.
Unlike you will observe without spots here, right?
Yes, sir. Yes, sir. Exactly.
So that makes it bit unusual. So more common things are sort of ankle edema, right? Wasting, muscle wasting, right? Hello, glossitis, those things, right?
Yes.
Rather than very unusual to get without spot.
Yes. So
We move on.
that concludes. Hello, sir.
Okay, at the end of your history and examination both, what is your impression, or what do you think this patient is having?
So this patient is having progressive dysphagia for 4 months with preserved appetite, and from this statement itself, hello, a lot of noises.
Can everyone please mute their mics? We are hearing a lot of noises from your surroundings. Please mute your mics.
So
Yeah,
from that statement onwards, itself, sir, points out to a esophageal more malignancy. And with the history and examination, there are no features of local or distant metastasis. However, the systemic in hello.
Here,
Hello.
Yeah, go on.
Hello, sir.
Supun, go on.
Yeah, we can hear.
Yeah. So from that, so I was, so I just told the statement. Were you able to hear me, or?
yes, yes,
Yeah,
I did.
go ahead. Yes, we have been hearing you all through.
So I'll repeat again, sir. So this again, 67-year-old patient with.
No, you don't have to repeat. We heard.
So, sir, three key elements of this summary. This is likely to.
Based on the question from enough Supun, I think you have already enough troubled enough now. We'll ask from Madhusanka now.
Right. Sir.
Madhusanka, yeah, are you there? Yes, Madhusanka.
Hello, sir. I'm here, sir.
Yes, you are there. Yes. Okay. Now, if this patient now you are the clinic you are in the clinic, this patient comes to you with this history, right? They have taken a history. What will you do now? What is your next step?
Sir, following the history and the examination, I need investigation, sir. First, I will proceed with the upper GI endoscopy, sir.
Right. Okay. Right. So,
What are the things that
you
you
had a
do?
picture? Yes. Okay. So now this is the endoscopy. Yeah. Do you think this endoscopy picture is compatible with this history?
Yes, sir.
So,
It's a
Mansangar,
malignant-looking
yeah.
growth.
Can you describe this? What you see? Let's say you do the endoscopy here. This is what you see. How do you describe this lesion?
Probably a malignant-looking growth, partially obstructing the lumen, sir.
Growth.
Growth, malignant. Why are you saying this is a malignant looking? Does it look malignant? I'm not sure.
Its surface and irregularity, and it's obstructing the lumen also.
Is it obstructing
I need the
lumen?
proximal and distal margins too, sir.
Where is this view?
What is this view?
Yeah, is it?
Sir, can
this
I
is
disturb for a minute?
No, don't disturb.
No, sir, this not photo is of this patient. I don't have a photo, sir. However, this is the only photo that was compatible with the upper GI
Can you
finding
please,
that we had, sir.
please shut up? Enough now.
Right, sir.
Can you describe this picture?
yes, sir. This is a view of endoscopic view of a gastroesophageal growth. Here we can observe the J view. It's more likely the malignant looking growth partially obstructing the gastroesophageal outlets. Junction, yes.
It's a junction.
Is it obstructing? I don't think it is obstructing. By if you see
it seems obstructing.
I don't think you write this in the report.
You can even see the esophagus from there.
Yes.
Yeah, you can very clearly see the esophagus and the junction. So
yes, sir.
Yeah. So where is the lesion?
It's in the gastroesophageal junction, sir.
I think
in the
cardia area. Junction, no? Not actually junction. Looks like in the
angle of his. Right?
Yeah. Now this gastroesophageal junction is there are different classifications. Exact 2 centimeters distal and proximal to the anatomical gastroesophageal junction is also considered as a gastroesophageal junctional tumors. So this is of course cardiac tumor, the tumor rising from the gastric cardia extending into the esophagus, and so this is also considered as a gastroesophageal junction tumor.
Yeah. Okay, but in this patient, probably this is not compatible with this picture, the history that the patient presented, no?
Yeah.
So you are still in dysphagia, only dysphagia, significant dysphagia, and there's no loss of appetite. So this is not the type of picture that you would see in this patient.
Yes, sir. So
so probably proximal or mid esophagus.
Yes, sir.
Most likely.
So for the compatibility, sir, I put another one photo, sir, which should be compatible with a history like this.
Yeah, okay. Right.
Right.
So
So,
Sumut sir, when you are taking biopsies, how
you said you want to do endoscopy. What is your intention or objective of doing endoscopy?
Sir, delineate the tumor. Sorry, sir, I'm not clear.
You said you want to do an endoscopy as the first line of investigation.
lesion like
Yes,
this.
sir.
So where do you take biopsy?
Hello.
There are a lot of noises near.
Yeah.
From where it comes. Now you said you want to do endoscopy. So what are your objectives or what are the things you want to find by doing an endoscopy?
Sir, for the diagnosis, I need to take biopsies and delineate the tumor, the proximal and distal margins, and the site of the esophagus, whether the involvement is distal or the proximal or mid esophagus, or involvement of the gastroesophageal junction, and see
I
the
would say
distal the
now
stomach to
the
observe the stomach pulses.
Idea of doing endoscopy in a patient with dysphagia primarily is to recognize the cause for dysphagia. That could be a
Yes,
luminal cause like this, or it could be something else also. Could be a foreign body,
yes,
could be even
yes,
esophagitis, stricture, right? So those
yes,
things are also possible. So if it is a tumor like this, you can take a biopsy from that. That will confirm your diagnosis. And at the same time, you want to assess the stomach as well.
yes.
Why do you want to assess the stomach?
If I am going for the surgery, stomach is the conduit, sir. So I need to assess it before the surgery.
Right. You would like to see the sort of status of the stomach because you are going to use it as a conduit. Right. Okay. Now,
Yes.
this patient, you thought it could be, it is very likely to be
Your mic is mute. Hello.
could it be a strict? Not this picture. The history, could it suggestive of a stricture at the gastroesophageal junction?
With the history alone, could it be? It could be a stricture, sir.
So what are the things in favor of a stricture there in the history? How do they get stricture? Strictures are usually due to two things, right? Either corrosive,
Yes, usually caustic or
or
corrosive injection,
other
and
possible
malignant strictures.
Malignant strictures occur on a corrosive stricture or peptic stricture. Right?
Yes.
The peptic strictures occur on sort of the patients who are having
History of GORD, sir.
Right? So this patient didn't have any of those things. Right? He didn't have reflux
Yes.
he didn't have corrosive history, right? Short history, right? So it is unlikely to be due to a stricture. Right. Now you have taken a biopsy. What are the possible histological types?
In lower esophagus, it could be most probably sir, adenocarcinoma, but still squamous carcinoma is a possibility.
Okay. Adenocarcinoma and squamous cell carcinoma are the common malignancies you get in the esophagus. Lower end adenocarcinoma is rising. The upper and middle, the squamous carcinoma is common. Right.
Yes.
Okay. If it is now histology confirmed, if it is confirmed adenocarcinoma, do you need any other information to treat this patient?
Yes, sir. I need to assess the I will go for the staging, and any I need to find out distant if there is any distant metastasis, as this is directly decide the surgery or the palliative management.
Okay, you want to see whether you want to stage the disease to find out whether he has got metastasis or not. What are the common sites?
Yes, sir.
Metastasis of esophageal cancer.
It's lungs and liver.
Right, those are the two commonest sites. Right, you can name any other organ. It is possible and it has been reported, right? But they are not that common. Okay. So, what investigation would you do to recognize this?
Initially, a CT contrast enhanced CT chest and abdomen, sir. And if available in EUS to see the depth of invasion.
Now you said your first intention, your first objective is of staging this disease is to recognize whether he has got metastatic disease or not.
Yes,
right?
sir.
Now, when we compare with rectal cancer, your objective is, it is not your objective, main objective, right? Here,
Yes.
that is your main objective. For that, you said you are going to do a contrast enhanced CT, abdomen and chest. I agree, right? Why do you want to do a EUS will it recognize metastatic disease?
No, sir, sorry. It's only for the initial early stages, the depth of invasion, T1 lesion.
Now
I just mentioned, sorry, sir.
Your main objective is to sort of find out whether it is operable lesion or not, no, right? I agree that you do a CT contrast enhanced CT.
Yes, sir.
Right. Contrast enhanced CT, if it shows evidence of metastatic disease, metastasis in the liver or lung, right? What would you do? Can you hear me? Can you hear me?
Initial part I didn't hear, sir.
If CT shows evidence of metastatic disease, what would you do?
Sir, my management goes for the palliation, sir. I can't think of surgery then.
Okay. So he is in the palliation. So
yes.
If there is no evidence of metastatic disease in the contrast enhanced CT, what would you do?
Still CT will not show small metastasis. If possible, I will go for a PET scan.
Okay. You will do for a PET CT scan?
Yes, sir.
Okay. Roughly what percentage of patients with negative CT may have a positive PET?
Sorry, sir, I have no idea.
Right. About 15 to 20% of patients with negative CT. Hello. Can you hear me?
Yes, I can hear you.
Yes.
Right. Will have positive PET scan. Right. Okay. Now, PET also negative, CT also negative. What do you do next?
Then, sir, my management, if the both CT and PET is negative, PET are negative, my metastatic disease is unlikely, sir. If the patient I am planning for the surgery, if the patient is fit for surgery, and I'll go for other investigations.
What are the investigations would you do?
The basic investigation to assess the patient's fitness for the surgery and other for the preparation for the surgery, sir.
Now, this patient, if the PET is negative and CT is negative for metastatic disease, so technically he is having operable disease in the way.
Yes.
So,
are there any other limitations for surgery? Is that all? I mean,
the determinant of that, whether he is benefited from surgery, is whether he can tolerate this surgery.
Yes.
So you are doing investigation to make sure whether he is whether he can withstand a major surgery. Hmm?
Yes.
So what are the specific investigations you would do? So basically, what are
the
the
cardiac
major
assessment,
killers? Right?
He needs a cardiac assessment and lung function test. As the main killers are the cardiovascular and respiratory complications.
So did he discuss about the local invasion?
yeah, that is important. I mean, if there are no metastasis, the lymph node status and local T stage or local infiltration are the important things. He didn't mention those.
No, we'll come into that.
Yeah.
The other two important aspects, you said cardiovascular, respiratory. The other two are the nutritional, right, and the oral hygiene also. Right? Those two are also very important. Right? Septic related complication can be significantly reduced by having good oral hygiene. Right? Nutrition, poor nutrition is a major cause for operative mortality. This is not cancer related mortality, those 4 areas. Okay. As Rohan sort of pointed out, just absence of metastatic disease will pass him for a curative surgery. Hello.
Madhushankar.
Okay, we'll get someone else then. Subhani, are you there?
Yeah. One is not there. Any other discuss? We last from
Yes, sir, I'm there.
Right. Okay. So what other when there are no metastatic disease, are there any other factors which will prevent you doing a curative surgery?
Yes, sir. And the tumor is infiltrate to the non-resectable structures like aorta, heart. It will non-resectable surgery. But pericardium involvement, can we go ahead with the surgery? Sir?
Okay. So those are the two main factors which will decide the operability. These are the three main factors which will determine the operability: metastatic disease, infiltration of a vital organ, and the physiological status to withstand this surgery.
So I have a question.
Yeah.
Yeah. Now, what about the involvement or presence of mediastinal nodes, presence of celiac axis nodes, and presence of maybe cervical nodes? With respect to the
lymph node involvement is not a bar for a curative surgery. Mediastinal nodes, celiac nodes, even cervical nodes. If there is evidence of cervical node, the problem is middle and lower one-third tumors, middle one-third and lower one-third tumors, the incidence of involvement of cervical lymph nodes is less than 10%.
Yeah.
It is commonly involved in the upper one-third tumors. and surgery is not the mainstay of treatment in upper one-third tumors.
Yeah.
Esophageal upper one-third esophageal cancer. So mainly we are targeting at mediastinal and cervical lymph nodes. If they are there, we do lymph node clearance as well. And present day, we don't do 3-field lymphadenectomy, but we do 2-field lymphadenectomy.
Yeah. What do you mean by 2-field lymphadenectomy versus 3-field?
3-field lymphadenectomy, we take cervical, mediastinal, and celiac group lymph nodes. But 2-field lymphadenectomy, we take only the mediastinal and cervical lymph celiac axis nodes.
Okay.
So basically, lymph node dissection is intracarinal.
Yeah. So when you dissect the celiac axis, so you take left gastric vessel from the left gastric, you divide from the left gastric trunk origin, but then you clear off all the lymph nodes around the celiac axis. Is that standard dissection for gastric cancer?
Yes. Yes.
Yeah. Okay. And so you other thing you mentioned about the PET scan, you said 15% CT negative, PET will be positive.
Yes.
That is very like firm data, or is it a
It's mainly nodal metastasis also, no, including nodes.
I thought it's for the nodal metastasis, the liver metastasis. That is what I felt, and that is what I for other lesions, not for the liver metastasis.
Only the nodal,
but
and the distal
sorry?
as
Nodes
well.
and
The lung mets and the distal mets as well.
Yeah, but still the lung mets. I'll have to refer it back. But for the lung mets and liver mets, still contrast CT is better than PET sensitivity. That's the problem is you will see a lesion, but the lesion, whether it is a met or not, we will not be able to tell. But seeing a solid or SOL in the lung or liver, CT is better. But to say it is a met, probably PET has advantage, but seeing a lesion is better with the CT.
Of course, because that is why we do a contrast enhanced CT first. Right? If we think it is negative, only we do a PET scan, PET CT. Right? PET CT will help us to recognize or to characterize the lesion, as well as all by the PET scan will recognize metastatic disease elsewhere also.
Isn't the MRI better than CT?
MRI is not a good investigation in esophageal cancer, not like rectal cancer, mainly because MRI is not a good tool to assess lung.
If the CT says suspected invasion, so we'll for a US for confirmation.
Now, once you do CT and PET scan, then if you think it is early lesion, then of course there is a place for EUS. If it is a tumor like this, almost involving 2/3 of the circumference, one thing is it is difficult to perform EUS. EUS is mainly to recognize early lesions which are amenable for more local treatment, to differentiate T1 lesions from T2.
So it will not confirm T3 like from T4, like going into a bronchus or the
T3, of course, yes, you can. Earlier people do sort of EUS guided lymph node sampling also, but it doesn't contribute for the management.
Right.
CT is good enough to sort of assess T3 and T4 lesions. CT is not a good investigation to assess T1 and T2 lesions.
Sir, which
sorry.
Hello, sir.
I have a question to ask about the upper GI endoscopy now. When you do upper GI, so where would you take the biopsies from? And how many biopsies do you require for it to have histological diagnosis?
Biopsy should be taken from the edges or the margins of the tissue, tumor. If you take it right from the center, you get more necrotic tissue, and pathologists may not be able to differentiate or tell more information about malignancy. So you take biopsies from the edge or the margin of the tumor.
And do you require to take some minimum number of samples, or is it just only one adequate?
No, usually we take more than one, but there is no such thing that you have to take 2 or 3 or 4. Nothing like that.
In situation where, let's say, the tumor is obstructing the esophagus, so in this situation, like how, if you can't pass a scope beyond, how do you take biopsies? If you do it, do you dilate and take?
No, that is not advisable to sort of dilate the esophagus and go through the tumor, because chances of esophageal rupture is very high, and if it is ruptured, the chances of it healing is very poor, and you may compromise the cure also if it is a curable disease. But if it is completely obstructed, the chances of having a curable disease is also very remote. We can take the biopsy from the top end if it is obstructing tumor. Right. So from here, probably shall we summarize the core knowledge for the medical students, benefit of the medical students?
Yeah.
I think the core knowledge, or the sort of the bare minimum knowledge you should have about dysphagia is a sinister symptom, right? You can't say it is physiological. There is nothing called physiological dysphagia. It is always pathological. And progressive dysphagia over a short period of time in older patients, right? If it is above 50, should be considered as esophageal cancer until proved otherwise. And the most important investigation in a patient having progressive dysphagia over a short period of time is the endoscopy. We do endoscopy to recognize the lesion, the site of the lesion, and take a biopsy for the histological assessment of the lesion and to assess the status of the stomach mainly. So in esophageal cancer management, in operable esophageal cancer management, two most important information are the site of the tumor and the histological type of the tumor. And to decide whether it is a curable disease in esophageal cancer is or incurable disease in esophageal cancer is a metastatic esophageal cancer. That is one group. The second group is esophageal cancer which has been infiltrated to a vital structure which cannot be sacrificed. Maybe heart, could be aorta, it could be major bronchus, but things like pericardium infiltrated onto the crura, that is not inoperable, that because that can be sacrificed. Then the first line investigations to assess the metastatic status are sort of contrast enhanced CT, chest and abdomen. If it is negative, if possible, we can do PET scan to see, to confirm any evidence of metastatic disease. Once you see sort of non-metastatic, non-infiltrating tumor, then this is a major surgery which involves in 3 compartments: neck, chest, and abdomen. I forgot to tell you the surgery is indicated in the middle and lower third tumors. Upper one third esophageal tumors are best treated with non-operatively with chemoradiotherapy. So, as this is a major complex surgery which carries a very high mortality, perioperative mortality, not related to the malignancy. The 30-day mortality of esophageal cancer is somewhere around 5 to 6%, even in best centers. So those patients die not because of the malignancy, but because of the surgical trauma. So we want to make sure that patients have enough physiological reserves to withstand this surgery, mainly cardiovascular reserves, respiratory reserves, nutritional reserves. Other main cause of death is septic or infection-related problem, which can be significantly reduced by having good oral hygiene. So improving oral hygiene, improving nutrition, improving cardiovascular reserves, and investigating to see whether he has adequate cardiovascular reserves and the respiratory reserves by doing lung functions is mandatory before surgery. If everything is okay, surgery plays the major role in cure. But having said that, surgical treatment in esophageal cancer, whether it is adenocarcinoma or squamous cell carcinoma, is not very successful or not very productive, not like breast cancer and rectal cancer. 5-year survival has been, when the surgery is the only arm of treatment, is less than 2 years. The mean 5-year survival, mean survival was about 20 years, 24 months. So recently, people have suggested or incorporated neoadjuvant treatment to improve the survival. So neoadjuvant treatment has improved survival of the esophageal cancer. The mean survival is somewhere around 48 months, twice that of that when we did surgery alone. So the next important thing probably the post-operative care of these patients.
What about, excuse me, so what about chemotherapy? Will this patient benefit from neoadjuvant chemotherapy?
The neoadjuvant chemotherapy was, now surgery alone, neoadjuvant chemotherapy was better than surgery alone. That was shown in MAGIC trial. This is mainly for the registrars, I suppose. For the medical students, if they know that neoadjuvant treatment has improved survival, that is, I think, more than enough. So the people tried chemotherapy, that is, MAGIC trial was mainly for the gastric cancer and the gastroesophageal junction adenocarcinoma. Right? So that has shown beneficial effects, right? Improved mean survival rate. But that was not done for the mainly for the, that was mainly done for the gastroesophageal junction and gastric adenocarcinoma. Cross trial is the one which suggested the benefits of neoadjuvant chemoradiotherapy. So that has clearly shown the mean survival following surgery following neoadjuvant chemoradiotherapy is 48 months. In the surgery alone arm, they did a randomized control trial. Surgery alone arm, the mean survival was about 24 months. So the twice the mean survival of surgery alone. So there is clear benefits of neoadjuvant chemoradiotherapy in both squamous and adenocarcinoma. But radiotherapy has been given even before a cross trial for squamous cell carcinoma. So there is not much of a difference in the management of squamous cell carcinoma, but people realize even in the adenocarcinoma, chemotherapy with radiotherapy has good benefits. One thing to now in the West, can you hear me?
Yes,
Yes,
yes.
yes.
Yeah, in the West, adenocarcinoma is rising, and the squamous cell carcinoma is not that common. And mainly squamous cell carcinoma you get in patients who do smoke a lot and patients who are having consume alcohol. So those group of patients are uh, not physiologically good as patients with adenocarcinoma. Their survival is their physiological reserves are already compromised. So most of these patients, the rough way of managing these patients now, adenocarcinoma, definitely they give chemoradiotherapy and followed by surgery. That is because now, you know, surgery and radiotherapy are the main armamentarian to deal with the local disease. Now, when we give radiotherapy for the, that is the most important thing they found in the cross trial. When they give chemoradiotherapy for the adenocarcinoma, including the gastroesophageal junction tumor, only 50% of them after giving chemoradiotherapy for the adenocarcinoma, only 50% of them had a R0 resection. So 50% had, the other 50% had R1 or R2 resection. These are the patients who had CT and PET scan found that it's an operable tumor. Squamous cell carcinoma, it was different. When you give chemoradiotherapy, the incidence of R0 resection is about 75 to 80%. And the patients who didn't have chemoradiotherapy, the R0 resection is less than 25%, right? So based on these three facts, people recognize adding radiotherapy is beneficial for both squamous and adenocarcinoma, right? But more beneficial in squamous cell carcinoma. That doesn't mean squamous cell carcinoma, squamous cell carcinoma is the only one which is benefited with radiotherapy. Did you understand that?
Yes. Yes. So you will recommend neoadjuvant chemoradiation for both types of cancers, and if the patient is not completely obstructed. If the patient is completely obstructed, do you still recommend doing a feeding jejunostomy and giving neoadjuvant therapy, or
stenting? Rather than feeding jejunostomy, if we can put a stent and giving neoadjuvant chemoradiotherapy is better.
Right. But wouldn't it affect your surgery afterwards with the inflammation?
No, stenting doesn't really. But if you had a feeding jejunostomy, of course, sort of, if you didn't have a feeding gastrostomy, it doesn't affect. Stenting doesn't really affect. You don't sort of get much of inflammation around the esophagus after that with the stenting. Not like rectal cancer. Neoadjuvant chemoradiotherapy with the rectal cancer, we wait for at least 12 weeks, definitely more than 8 weeks. But esophageal cancer, after neoadjuvant chemoradiotherapy, we do operate before 4 weeks. So we do early, we have an early approach for the surgery in esophageal cancer.
So now, when we do the resection, say now we do this operation, do you have to think about the clearance margins? Is it 10 centimeter clearance margins? So,
initial, I think Bailey and Lau 11th edition, which was when I was using it. Now it must be 30 probably. It says 7 centimeter clearance margin. But when you take a esophageectomy specimen, the entire esophagus, I don't think you will get more than 10-12 centimeters. Esophagus shrink a lot when it is dissected. So if the tumor is about 2-3 centimeters from either side, you will never get sort of that big margin. And so that is based on the fact that submucosal spread in the esophagus is about 5 centimeters. So give a margin another 2 centimeters, they say they have to take 7 centimeters. This is the era where radiotherapy was not added as a neoadjuvant treatment. Now radiotherapy, when it is added as a neoadjuvant treatment, we are not hunting for that big margin.
Okay.
Yeah.
So,
Yeah,
are
just-
there any decisive factors, or you would recommend every patient gets neoadjuvant chemoradiation nowadays?
Yes, after cross trial, even there was a recent article by the sort of Sloan Kettering Center for Cancer. They definitely suggest neoadjuvant chemoradiotherapy both for adenocarcinoma as well as squamous cell carcinoma. But they say now there's a new trial. What they say is now the registrar should know there are mainly 3 trials important in esophageal cancer management. One thing is the MAGIC trial, other thing is the PROS trial, and the other thing is the KEYNOTE trial. The recent KEYNOTE trial, all these trials has nothing to do with the surgery. Now, the rectal cancer operations, the surgery makes a big leap. That is mesorectal excision. But in esophageal cancer surgery tried in a big way, Akiyama 3-field lymphadenectomy, but didn't improve survival or even morbidity. So it is not the surgery which improved survival and the disease-free survival in esophageal cancer. It is the adjuvant and the neoadjuvant treatment. And after the cross trial, people realized the importance of radiotherapy. And Sloan Kettering, they now, as I said, sort of 90%, about 80%, they have R0 resection following chemoradiotherapy for squamous cell carcinoma. Sometimes they observe patients after chemoradiotherapy without doing surgery for squamous cell carcinoma. But this is not in NCCN guidelines, right? Say they observe because squamous cell carcinoma, they respond more than adenocarcinoma, but adenocarcinoma, definitely you have to do surgery. And the KEYNOTE trial has suggested different chemotherapy regimes. Now, the standard chemotherapy regime for the esophageal cancer was FOLFOX. So after that, they were using more targeted therapy and the immunotherapy for esophageal cancer. And that has shown mainly beneficial effects in the squamous cell carcinoma. So main advantage in survival in esophageal cancer during last decade or last 2 decades, mainly due to neoadjuvant radiotherapy and the more targeted chemotherapy, immunotherapy, and anti-epithelial growth factor receptor antibody treatment.
So I have a question now. When it comes to surgery, now you said the standard is the 2-field esophagectomy. So now, but what about the IVLVs and the Oringer? Is it out now, or is it not?
No. The concept is sort of you can do 2-field lymphadenectomy transabdominally, transthoracic, and laparoscopical. So all these methods, transabdominal, transthoracic, and laparoscopic approach, is only an approach, but the surgery should include 2 fields of lymph node dissection.
Okay. So does the
You
microscopic
must be thinking transhiatal esophagectomy won't take mediastinal lymph nodes. You just blindly mobilize the esophagus and take out. The correct transhiatal esophagectomy is not a blind surgery. You enlarge the esophageal hiatus and use a retract and retract it anteriorly. Then you can see the carina, subcarinal area from the abdomen. So you do a sharp dissection and take all the subcarinal lymph nodes. We don't now take thoracic duct, ascites vein, pericardium, which were incorporated in Akiyama procedure. You don't have to take those things. Mainly because radiotherapy take care of that.
All right.
Yeah. For the students, like there are maybe 4th year, 3rd year, final year registrars, senior registrars, and even for us, I think. I mean, we discussed a lot of things. We discussed some of the basics and some of the advanced things, some of the really advanced things, like quite a range of things. How you learn from exercise like this is when you hear new word. Like now, probably for some, you would have heard R naught resection. So, and some would have heard the new term like neoadjuvant treatment, magic trial. What is neoadjuvant chemoradiotherapy? So when you hear a word like that, you read around that. You go and read what the magic trial is. At least read the abstract and see what does it discuss about. And that is how you learn your new things. That is how you expand your knowledge. You can't just become you start registrar will not become someone who's at a higher level than that. So it's a gradual process, but that you don't have to wait till you pass the exam to do that. So whenever you find something new, you read around that and expand your knowledge, and that is how you improve your knowledge. And today I heard one of someone telling, for last 5 years, he said for last 5 years from Ragama faculty there is not even single student apart from Pramod who has become first, or who has at least been the first 5 in MS Part 1 exam. For last 5 years, there's no one from Ragama. So that is a bad comment. That is a bad comment about Ragama when it comes to surgery.
Yes.
Yeah.
That's true. Okay. Oh, they are a gem.
I think it's all to do with the interest. Most of these students, when we even see the feedbacks, your objective is totally about passing the exam. Yes, we know that it's a priority, but you must also learn things for the sake of education. You need to learn things rather than just to pass the exams, because you're going to be a doctor and you should know things rather than getting MBBS and going as a empty person into the society with an MBBS. So it's very important, as Rohan sir said, if you gather that when you hear a word that you haven't heard before, write it down and go and find out. Now you have Google. You don't need to go to the library. You have Google. Just Google it and find out R naught resection, R1 resection, US magic trial, cross trial. So just, I mean, it's about improving the quality. 10 years back, students wouldn't have heard the word magic trial or cross trial, but now it's good that you know something. You know that there is neoadjuvant treatment. I mean, nobody will expect you to formulate a management plan for esophageal cancer at this stage, but it is very important that you have an idea when you hear someone saying, okay, we are sending this patient for neoadjuvant chemoradiation, that you're not lost. You know that, yes, it's an option. It's an option that is available. Because this is esophageal cancer, as Sumudu sir always says, is very, very easy. You're deciding operability versus non-operability, right? If you offer operable only, your rest of your plan works. And if it's non-operable, you know that it's just for palliation, right? So it's a very clear-cut sort of a disease rather than something like rectal cancer.
Just to tell them sort of now R0 and R1 resection is sort of completeness of your surgical resection. When you resect and send it for histology, they see the tumor, how close to the resection margin. If the resection margin is free of tumor, we call it is R0 resection. Now for esophageal cancer, we take it 1 millimeter. Certain breast cancers, I don't know what is so the breast cancer also it takes at 1 millimeter, is it? Can you hear me?
Yeah.
Deep margin, yes.
Yeah, or it's 1 millimeter. If it is microscopically R0, it is 1 millimeter.
1 millimeter, right? So likewise, so it is a clearance of the tumor from the surgical resection margin. And just to now, because there were a few students, medical students, worry about sort of they express that they can't differentiate the depth of knowledge which is required for them. It is difficult to say the depth of knowledge required for them, but there is when I assess, when I read something also, we grasp the core knowledge, the bare basic knowledge. Without that, we can't survive. Then there is another aspect, just good to know knowledge. And if you are really smart, you can acquire certain other things. So basic, the bare basic and the core knowledge of esophageal cancer, I suppose, is histologically there are two types: adenocarcinoma and squamous cell carcinoma. And the main investigation to diagnose the esophageal cancer is endoscopy. It is and the biopsy, and endoscopy and biopsy is the mainstay of diagnosing the esophageal cancer. And once it is diagnosed, we have to make sure, or we have to find out whether it is a curable disease or not. Curable disease is the disease without metastatic disease, or without infiltrating into a vital organ, or patient who can withstand a major surgery. So you have to do a CT, PET CT to assess whether it is metastatic disease or not, and whether it is infiltrated into a vital organ. Then you do other investigations to assess the fitness for surgery, mainly the cardiovascular, respiratory, nutritional assessment. So other surgeries you may not do lung functions, but here we do lung function. Echocardiography is done in most of the other surgeries also, but dental assessment and oral hygiene is specially assessed in a patient who is undergoing surgery.
Can't hear.
Yeah.
Of esophageal cancer has improved over last 20 years, mainly by adding neoadjuvant chemoradiotherapy that is effective for both adenocarcinoma and squamous cell carcinoma. I think that is the core knowledge for medical students, and good to know knowledge is for the registrars. There are 3 important trials mainly on the efficacy of neoadjuvant treatment, the place for radiotherapy and the type of chemotherapy. Those are MAGIC trial, CROSS trial, and the KEYNOTE trial. So if you have time, read about it as well. And the type of surgery, esophagus is a structure which goes from the mouth to the stomach. So it involves 3 main compartments: neck, thorax, and abdomen. So surgery can be done through the thorax, because the major part of the esophagus is in the thorax, or through abdomen, or keyhole surgery, which is called video assisted surgery. So whatever you do, the principle is to take the esophagus and along with the lymph nodes, mainly the celiac and the mediastinal group of lymph nodes. Anything to be added, Rohan? that is good to know.
Non-operative, we'll have to just touch on the patients who are not suitable for surgery.
Right. The surgery is not a, earlier we used to think that surgery is also a palliative modality of treatment. Nowadays, there are less invasive palliative modalities. So, less invasive palliative modalities are stenting. Then one thing is, I think for the registrars, SRs, it's important to know about management of the early esophageal cancer, the T1 lesions, right? The other modalities of managing T1 lesions. Then the place of mediastinoscopy, place of EUAs, and the place of laparoscopy, place of mediastinoscopy, bronchoscopy, those are all other adjuvant or ancillary investigations we do, not in all patients, but in special circumstances. I think registrar should know when you should order a bronchoscopy in a patient having esophageal cancer, when you should order a mediastinoscopy if it is available, laparoscopy for patient with esophageal cancer, likewise, and EUAs, right? Those investigations are not done for all patients. Then what else?
Sir, can I ask one question?
Shall we just we let them ask questions now if there are questions?
Okay.
Sir?
Yeah.
Yeah.
Sir, recently about a patient, you mentioned the word CPET, cardiopulmonary exercise tolerance testing. So, is it available in Sri Lanka? And so, because when I was reading it, it was a good test to replace lung functions and cardio.
Yeah. It's available in Sri Lanka. It's available at King's Hospital.
Yes. It is available.
So, is it more beneficial than doing lung functions itself?
It is a
yeah.
benchmark test for fitness. It assesses both lung and cardiac plus your physiological capacity.
Right, sir. So, if we say that if we have all the facilities, we are directly going for a CPET.
Yeah.
Yes.
Will we be in trouble, sir?
Why should you be in trouble? Yeah, be careful when you give answers still at this point. I think depends on maybe in the exam. You have to be balanced answer, I think.
Yeah.
I think we should not be talking about the exams, how to answer in the exam. It should be not the tone that we discuss things here, I think. Maybe for...
Sir, what is the place? Hello. Sir, what is the place of staging laparoscopy in esophageal cancers? So, in like what kind of patients do you advocate it?
Yeah, staging laparoscopy has a benefit in sort of mainly the gastroesophageal junction tumors, and what they do is they look for the liver mets, peritoneal mets, and the fixity of the tumor at the gastroesophageal junction also. And some people take a cytology sample. They prepare a cell block by infusing peritoneal cavity with about 1 liter of saline and take at least about 750 bags and preparing a cell block from that. And if it is positive, they don't. They consider it as a metastatic disease. So it has a place.
Thank you, sir.
So I have one question, sir. Sir, for esophageal cancer, sir, for the palliative care, sir, what are the main modalities and main principles in palliative care, sir?
Now, palliation is sort of palliating a symptom. It is not curing the disease. So that all depends on what you are going to palliate. If he has dysphagia, the main modality of palliation is placing a tube across it, not a jejunostomy or gastrostomy, because that will not relieve dysphagia. If it is bleeding, you have to stop bleeding. Again, the stent can do that, or you can sort of use APC as well, argon plasma coagulation. So palliation basically depends on what you are going to, or what is the symptom you are going to palliate. And the other palliation modality is chemoradiotherapy. No. There is palliative chemoradiotherapy for esophageal cancer as well. That will retard the tumor growth and cause more fibrosis of the tumor. And it improves survival a little bit, but not significantly.
Thank you, sir. And sir, after esophagectomy, sir, we say in the post-operative period, sir, we say that we should start feeding them. Like, what is the preferred route and how early we should start feeding them, sir? Like nutritional wise.
Now, most of these patients, now early feeding is very important after esophagectomy, because initially also they are malnourished, and we don't want to prolong the catabolic phase. For that, it is very important to feed them as early as possible. But there are two main problems of feeding them early. One thing is they don't have an anti-reflux mechanism. So, and the stomach reservoir is smaller. So the chances of aspiration, and during the esophagectomy, if you are doing anastomosis in the neck, the sensory branches of the recurrent laryngeal nerves, if it is compromised, the chances of aspiration is also more, because the pharyngeal sensation is lost. Due to these three reasons, they are having a higher risk of aspiration. Less stomach reservoir capacity, absence of anti-reflux mechanism, and the pharyngeal denervation of the recurrent laryngeal nerve. So if you go and damage the recurrent laryngeal nerve, that will be further aggravated, right? That is also possible, the left recurrent laryngeal nerve, which is because it is in very close proximity to the esophagus, that is in the tracheoesophageal group. So if the patient get aspirated, there will be a lot of problems of recovery, and it increases the perioperative mortality as well. I said perioperative mortality in esophageal cancer is somewhere around 5 to 6% in even best centers. So the safer way of feeding them is through a feeding jejunostomy or passing a nasojejuno feeding tube during the procedure. So both are accepted, and that will help us to start feeding as soon as possible, preferably from the day one onwards.
Thank you, sir. And sir, one another question, sir. Esophageal cancer, sir, we say that the patient's appetite is preserved, but there's loss of weight. But in the gastric cancer, we say that patient has both the loss of appetite and the loss of weight, sir. Is that due to the reduced gastric reservoir, sir? The patient is having loss of appetite, sir?
I don't think gastric cancer significantly compromise gastric reservoir. I don't know exact answer or correct answer why gastric cancer causes loss of appetite. Rohan or Pramod, do you have any idea about? Rohan,
So, yeah.
Pramod?
Is it to do something with the leptin hormones about the satiety? I'm not sure entirely. Has to do something with the infiltration of the fundus, and I think there is sort of a feedback mechanism with the hormone called leptin, isn't it? Which causes satiety. And also, I think the tumor necrosis factor and all these cancer cachetic substances that causes loss of appetite. yeah, I don't have any specific into that. I think there are so many theories postulated like that.
Yeah.
Thank you, sir.
So, excuse me, sir. When are we considering palliative surgery for esophageal carcinoma, sir?
I said sort of there is no place for palliative surgery in esophageal carcinoma nowadays because we have a less invasive palliative modalities. But having said that, uh, having said that, when we do surgery for esophageal cancer, during surgery we may come across, suppose if you have already mobilized the esophagus from the thorax, and when you come to the abdomen, you see a small liver deposit. Right? You can't leave that esophagus and come because it will necrose and stuff. So then you have to do a gastric tube and bring it up to the neck. So we are not intentionally doing palliative esophagectomies, but sometimes we may have to accidentally do palliative esophagectomy. It's Supun who asked that, no?
Yes, sir.
Supun, may I ask a question? When you are doing the esophagectomy, now I said sort of you have a component to be done in the stomach, you have a component to be done in the esophagus. Which component is done first? The thoracic mobilization or gastric mobilization?
So this is Supun is not a registrar.
Right. Sorry. Any registrars?
So I'm not sure of the answer, but I think there are benefits of doing the gastric mobilization first, because if we detect other like peritoneal spreads or liver deposits at the time of the surgery, we can safely abandon the surgery at that time rather than doing a thoracic mobilization first.
Right. If it is infiltrated to the trachea, if it is infiltrated to the aorta, inferior pulmonary vein,
yes, sir.
when
Yes,
sort
sir.
of, you don't find any metastasis in that, and sort of when you start with thoracic mobilization, what to do now?
I would
There is no
probably,
fixed answer to this thing. Now, you
yes.
may be flash this kind of questions in the exam, right? These are just to see how whether you are a thinking person or not, right? So there is nothing like that you have to start from the gastric or the from thoracic mobilization. But some people prefer to sort of do a thoracic mobilization first, while others prefer to do a gastric mobilization first. But there are certain principles. One thing is when we are dealing with a tumor. Now, if we have reasonably good pre-op workup with the PET and CT, we have reasonably satisfied that patient is not having a metastatic disease. So if the patient's tumor is in the esophagus or it is in the thorax, you should be able to, I think you should try and mobilize the primary tumor first. If it is a gastroesophageal junction tumor, of course, you may approach from the stomach. If it is above the gastroesophageal junction in the thorax, you do a thoracic mobilization first. But there is no hard and fast rule.
Technically, also it will be easier when you have to turn the patient twice, otherwise do the gastric mobilization, turn to the prone, and then turn again, because you can't make the gastric tube and complete it because you don't know what's happening in the thorax. Right? Yeah. So, yes. Any other question?
So lymph, in comes to lymph node harvest in rectal cancer, we say that it has only a prognostic advantage. But here, sir, again, is it just prognosis or does it have a survival benefit in esophagus?
difficult question to answer. I believe all lymph nodes have a prognostic implication rather than a therapeutic implication. But in esophageal cancer, it has not been, I haven't found any documentation regarding this. But the things they suggest is lymph node harvest. They say the esophageal cancer N1, N2, N3 based on the number of lymph nodes they harvest, and of course that will that has a prognostic implication. My gut feeling is lymph nodes in rectal cancer, breast cancer, and esophageal cancer has a prognostic implication rather than a therapeutic implication.
Right, sir.
Any other questions at this time?
It's quite late now, isn't it?
Sir, when staging the disease, sir, when do we do bronchoscopy and laparoscopy, sir?
The thing I wanted you to read. Right. Okay. If the patient is having any evidence of bronchial infiltration, that is recurrent cough, recurrent chest infection, or CT suggesting the tumor at the carina or just above the carina, because below the carina, sort of chances of infiltrating into the bronchus or the trachea is very minimal, right? Or unlikely. So then if it is at the carina or above the carina with these symptoms, you tend to do a bronchoscopy.
Thank you, sir.
Yeah, so in the absence of any other questions, shall we wind?
Excuse me, sir. When it comes to adenocarcinoma of the esophagus, which might be inoperable, is chemotherapy best in that case? Is there anything like that, sir? Adenocarcinoma palliative chemotherapy is better than.
Yes. Now, if it is operable, of course, neoadjuvant chemoradiotherapy followed by surgery is the best form of treatment. When it is inoperable, there is a place for palliative chemotherapy, right? And you palliate other symptoms as well. If he is having loss of appetite, we can sort of give appetizers. If he has bleeding, we can sort of arrest bleeding by argan plasma coagulation. Usually, the gastroesophageal junction tumors, if it is obstructing, you may have to palliate it with stenting. So, like this, you palliate the symptom, and there's a place for palliative chemotherapy also.
So the palliative chemotherapy is for both inoperable squamous cell carcinoma and adenocarcinoma.
Squamous cell carcinoma, we give palliative chemoradiotherapy.
Okay. Thank you, sir.
Right. Okay.
And sir, the third tumors, sir, the surgery is not the main modality of treatment. Yes, sir. Like for that, the main modality of treatment is that chemoradiotherapy, sir, for the upper one-third tumors.
Yes, upper one-third tumors, squamous cell carcinomas, the main modality of treatment is chemoradiotherapy. Because if you go and do a radical surgery there, you will do a laryngectomy also. So they will have a lot of morbidity. They can't talk, they can't swallow. And the outcome results are more or less similar. The mortality, the survival benefits, there is no added survival benefits by doing surgery. Right? Even in the now Sloan Kettering, they advise you give now the word they use is for the squamous cell carcinoma without infiltration and no metastasis. What they suggest is to give definitive chemoradiotherapy and observation. Right? If you give definitive chemoradiotherapy and the regress, right? If there's a complete pathological response, you don't have to do a surgery. You observe. And if you find sort of if they don't have a complete pathological response, of course they suggest surgery. There is a good proportion of patients with squamous cell carcinoma with the definitive chemoradiotherapy. The word, not the neoadjuvant, the definitive chemoradiotherapy will have a complete pathological response.
Thank you, sir.
Yeah, I think we'll wind up now, isn't it? Okay, then thank you very much, everyone. And I will post this on the Facebook page, so anyone who missed can join later. Okay, all right then.
Okay.
Good night.
Okay, thank you.